Thank you for introduction, Professor Bugert. Hi, everybody. I'm Naoto Takahashi. Came from Japan. My specialty is GI surgery. I have no COI in this presentation. GK University was founded in 1881 by Professor Takahashi, who was famous as the first medical scientist in Japan to conduct the large-scale clinical trials. He belongs to the Navy, and he discovered an effective dietary treatment for beriberi using white rice and mixed grain rice. This later contributed to the discovery of vitamins. I work at the Kashiwa Branch Hospital near Tokyo. I'm going to talk about 3 topics today. I will first introduce the concept of the significance of Sentinel navigation surgery for gastric cancer. Next, I will share you my experience of Sentinel navigation plus minimum gastrectomy. Finally, I will present the application and the potential of endoscopic fluorescence clips in this context. Recently, the population of early gastric cancer has increased to more than 60% in Japan. Total lymph node metastasis in early gastric cancer ranges from 5 to 20%. More than 80% of patients with early gastric cancer undergo unnecessary wide excision of the stomach with aggressive lymphadenectomy. So the need for a tool that exactly predicts the lymph node metastasis impairment. With such a tool, we can opt for the wedge or segmental resection without unnecessary lymph node resection, significantly increasing patient of QOL. The Sentinel lymph node theory is also attracting attention in the field of gastric cancer as a tool for detecting lymph node metastasis. Many investigators have already demonstrated the clinical utility of Sentinel navigation for patients with gastric cancer. There are 2 important clinical studies for Sentinel navigation surgery conducted in Japan. These 2 studies are critical and the foundation of the Sentinel navigation surgery today in Japan. First, the center of the belongs to the Japanese Association of Sentinel navigation surgery, and right side is the JCO group. Indication is a pretty difference in T1, T2 less than 4 centimeter our group, and T1 less than 4 centimeter JCO group. Okay.
A little light here.
Thank you.
A little light there.
Thank you, Rahul. So tracer, we use a double tracer method, blue dye or ICG, and radioisotope. JCO group use only ICG, not infrared method. Tracer administration is very different. We use the submucosal layer, injected to the submucosa. However, JCO group in directly serosal surface. And this is very important. So the Sentinel collecting method is different from the 2 groups. We use lymphatic basin resection and JCO group pickup. So detection rate is almost same. However, false negative rate is very low in 1% versus 14. So JCO groups suspended this methodology, and we further the study now ongoing. Based on the result from the pharma study, an indication in concreted the patient with a T1 less than 4 centimeter. The characteristics of the 4 false negative cases in the Sentinel navigation study group in Japan were those with a tumor less than 4 centimeter deeper than T2 in depth. The double tracer method was recommended. The radioisotopes injected on the day before surgery. ICG or blue dye injected in the submucosal layer surrounding the tumor intraoperative endoscopy. Lymphatic-based resection should be performed. We are conducting the Prospect Mass Center clinical research on the laparoscopic function-preserving gastrectomy using Sentinel navigation surgery for early gastric cancer. We are currently in the observation period after patient recruitment, but the primary endpoint of the 5 years survival rate will be revealed in this year. So, if intraoperative pathological diagnosis, Sentinel lymph node includes metastasis, we perform the standard gastrectomy. However, negative for metastasis, we choose preserving resection. This picture is, left side is, he is Dr. Liu, he is Mr. Senorita in South Korea. And the left side, he is Professor Kitajima. Kitajima is a very famous Japanese surgeon. We conducted as Sentinel navigation surgery. So the Senorita trial in South Korea proceeded the prospective clinical trial of reduction surgery based on Sentinel biopsy. Results for the primary endpoint have already been published in 2022. The table compared with the clinical trials in Japan. Early gastric cancer up to 3 cm in Korea and 4 cm in Japan has been registered. Unfortunately, due to the treatment of metachronous polygastric cancer, the non-inferiority of 3 years disease-free survival was not confirmed. However, quality of life was better in the reduction surgery group. 5 years follow-up results were also reported, and there was no difference between the 5-year overall survival and the disease-specific survival compared to standard care. We will have no wait for the result in Japan for the file. So, excuse me. This picture is Dr. Narimiya. Dr. Narimiya examines the vessel in the stomach. So, and excuse me. He is Dr. Nimura. He is my best career, and he helped me to study the Sentinel navigation surgery for me. So we initially identified the Sentinel lymph node by ICG absorption imaging and reported good result in 2003. It is easy to identify the lymph node predominantly by absorption imaging. Excuse me. So we can, we can easily detect the lymph node and the lymph vessel. This is infrared method and absorption imaging. This is a result of in our absorption imaging result. 84 patients were enrolled. 11 patients had lymph node metastasis. Infrared ray examination detected all 11 cases. However, ordinary light detected only 7 cases. There are 2 images in the ICG plus infrared ray method, such as absorption imaging and fluorescence imaging. Center of picture is absorption imaging, and the right side is fluorescence imaging. So absorption imaging for sentinel mapping against the gastric cancer is very elegant. However, this method is not widely accepted because of its versatility. It is used only to detect sentinel lymph node of gastric cancer. With the development of medical devices, fluorescent imaging has progressed from black and white image to the color image. The Da Vinci now comes a standard with the infrared method. This slide shows our indication for sentinel navigation strategy. Indication of sentinel lymph node injected in the submucosal layer of the intraoperative endoscopic. After 20 minutes, infrared observation was performed, and the basin resection, including a green lymph node and a lymph vessel, was done. When intra-rapid pathological diagnosis showed a negative, wedge or segmental resection was applied. These are short videos of the indication of sentinel lymph node metastasis, sentinel lymph node by ICG. The left one was pretty old one. The early stage of cancer is located on the lesser curvature of the caldera. Infrared observation reveals the sentinel lymph node on the both greater curvature and the lesser curvature. In absorption imaging, lymph node and the lymphatic vessel appeared black, whereas in fluorescence imaging, they appeared white. Now, in the lymph vessel this is fluorescence imaging. On the other hand, the right side shows the current fluorescence observations, especially around the 7th lymph node area. In the color image, green lymph node and the lymphatic vessel can be seen. These can also be observed in the final black and white. This figure shows the case presented in the video on the left in the previous slide. Sentinel lymph node in 4SB or 4SB, as well as the number 3 and 7, were identified and removed using the basin dissection. Intraoperative rapid pathological diagnosis confirmed no metastasis, so wedge resection was performed. Take a look at the size of the resected stomach. It's only about 5 centimeters square. The post-operative endoscopic images show the clean anastomosis site. This patient was experiencing no weight loss after the surgery and remained in the excellent health. Of course, there has no recurrence, and the patient has survived for more than 5 years. Let us present our data from 2010 to 2024. We performed the sentinel lymph node guided surgery on 112 cases. Due to the historical context of the observation method, the cases were divided into the 3 groups. Group 1, absorption imaging without RI. Group 2, black and white fluorescence imaging without RI. Group 3, colored fluorescence imaging with or without RI. In Group 1, there were 19 cases. In Group 2, 38 cases. And Group 3, 55 cases. The sentinel identification rate was 100% in all groups. 2 cases metastatic lymph node were identified in each group. There are 2 false negatives in group 3, but both were cases of micrometastasis with isolated tumor cells. 76.4% of patients received a limited gastrectomy, including a wedge or segmental gastrectomy. Surgical outcomes. So the key point is highlighted in this third item, the weight loss rate. Typically, distal gastrectomy results in approximately 10% weight loss, and the total gastrectomy leads to 15 to 20% weight loss. However, with local resection, the weight loss limited to 4%. With segmental resection, it remains 6%. As gastric cancer in Japan continues to affect the aging population, it is essential to promote with widespread adoption of this surgical method to prevent issues such as frailty. In summary, wedge resection and segmental resection by Sentinel navigation result in a minimal weight loss and considered to be a new treatment option for early gastric cancer. The next main theme I will discuss today, fluorescence clip marking ZeoClip FS. This endoscopic clips contains a resin that shows a near-infrared fluorescence produced by Professor Yoshida. They make easy determination of a tumor location and the incision line. This clip requires some technique when used on the stomach. Since the gastric wall is thick, it is necessary to slightly pull the stomach stretch and since the wall of the bright camera is closer. We stretch the stomach wall, and I can see the fluorescence and by clip. This is conclusion. ICG fluorescence guided sentinel navigation surgery for early gastric cancer is a promising technique to reduce unnecessary extensive lymphadenectomy and the amount of gastric resection. Fluorescence clip is feasible and safe, can be used as tumor marking against determined accurate surgical resection lines. Thank you for your kind attention. Thank you. Thank you again.